Chairwoman Mikowski, Vice Chairman Schatz, and members of the committee, on behalf of NIHB and the 574 federally recognized tribal nations we serve, thank you for this opportunity to testify. My name is A.C. Locklear. I am a member of the Lumbee Tribe of North Carolina and serve as a Chief Executive Officer for the National Indian Health Board, the only national tribally led organization dedicated to advancing the health of all tribal nations. For more than 50 years, NIHB has worked to ensure that the United States meets its trust and treaty obligations to tribal nations, obligations affirmed in law that do not stop during government shutdowns. While IHS plays a central role, the duty to provide for the health and well-being of American Indians and Alaska Natives extends across all of HHS. According to OMB's 2024 Native American Funding Crosscut, HHS administers over $12 billion in Native-related funding. Yet HHS still lacks comprehensive department-wide crosscut on how these dollars and others reach tribal communities. Without it, it is difficult to show how rifts and the shutdown disrupt services. Every day, the ITU system, including federal, tribal, and urban programs, relies on federal appropriations to pay staff, keep clinics open, and provide life-saving care. When that funding stops, even briefly, the impact is immediate and severe. Before advance appropriations, IHS was the only federal healthcare agency without funding during shutdowns. Clinics reduced critical services, providers went unpaid, and tribes relied on emergency funds, even facing credit downgrades and real-world impacts. In one tribal community, the inability to sustain operations led to the loss of 10 community members' lives. Thanks to congressional action and this committee's leadership, IHS continues full operations during this shutdown. No closures, no furloughs, no missed payments. When severe storms struck western Alaska earlier this month, the Yukon-Kuskokwim Health Corporation responded immediately because it was funded. That's what stability looks like in action. But gaps remain. Roughly $1.3 billion across 6 IHS accounts are not covered by advance appropriations. For now, IHS is covering those costs while also ensuring that commissioned Corps officers in tribal facilities continue to receive pay. But that stopgap is unsustainable. Similarly, the Special Diabetes Program for Indians is also affected. As the nation's most effective initiative for combating diabetes in Indian country, SDPI is responsible for an 84% drop in uncontrolled diabetes-related hospitalizations, and estimates show it saved IHS between $174 and $520 million in healthcare costs. SDPI has had only minimal increases in recent years and lacks stable multi-year funding. This shutdown puts the program in jeopardy, forcing IHS to rely on unobligated balances to keep it running. NIHB strongly supports the permanent reauthorization of SDPI and no less than $20 million annually with automatic funding increases. Programs like SDPI prove that predictable and advanced funding improves program outcomes, extends lives, and upholds a federal trust responsibility. Advance appropriations work. Now every tribal health program must be protected so tribes never face a lapse in care. Additionally, workforce reductions are eroding capacity across HHS. We're grateful that Secretary Kennedy is protecting IHS and tribal affairs staff from the deepest cuts. Still, IHS and other health program staff are not fully exempt from hiring freezes and workforce impacts. The Voluntary Early Retirement Authority saw IHS lose over 1,000 employees through retirement attrition. Since then, over 500 positions have been filled, while the agency faces the lowest offer acceptance rate in its history and a 30% overall vacancy rate. 43% of IHS facilities are so thinly staffed that losing just one physician could force closure. These losses translate into preventable deaths in tribal communities. Across the rest of HHS, rifts and hiring freezes has further reduced workforce that tribes rely on for grant management and critical technical assistance. At the Community Administration for Community Living, regional administrators who once served as direct points of contact for tribes were eliminated earlier this year, leaving tribal programs navigating this complex system on their own. Shutdowns and rifts are not just fiscal events. They directly weaken the government's capacity to meet its trust and treaty obligations. As Native communities confront the nation's most severe health disparities, we need to strengthen, not weaken, the federal health infrastructure that underpins tribal self-determination and the well-being of our people. We must extend protections to all IHS accounts, rebuild the workforce, permanently reauthorize SDPI, and improve coordination across HHS through a true cross-cut of tribal health funding. Our sovereignty does not shut down. The federal trust responsibility cannot be reduced in force. Thank you, and I welcome any questions you may have.